Hello.
Good morning.
Hi.
How are you?
I'm good. Nice to see you.
Well, thanks for doing this
Well,
on a Saturday morning.
oh, glad to do it. And really so nice to meet you. And where are you located?
I'm in Atlanta.
Okay.
Are you in New Orleans?
No, I'm in Baton Rouge.
Okay.
So,
Well, this is going to be very helpful. My audience is particularly um the term lost moms very well. So newly in their loss, trying to get answers, trying to navigate life afterward. This is going to be episode like 78. So I've been doing this for about a year and a half.
wow.
Um, Yeah, I started it on my son's 6th birthday, or 6-month birthday, excuse me. And yeah, it was really just an outlet for myself because I found that conversations with lost moms was the only thing that was helping me. So I just started recording my conversations and I threw them on the internet. And here we are, 50,000 downloads plus. So this is going to be heard by those who are seeking out answers, and kind of wanting to know more, not only just for closure on what happened to their babies, but for subsequent pregnancies,
Oh,
because
yeah.
we got to know what we're working with here. So I really appreciate you giving your expertise on this. I want to start with your background, though. Can you kind of give us a little rundown on how you became such an expert in this subject?
Well, I'm practiced solo OB for over 30 years. And I had an event that was very unusual. The patient, her first name was Debbie, went fishing in Lake Pontchartrain with her husband on a Sunday and called me on a Monday morning saying the baby wasn't moving. So I told her I would meet her at the office at 8 o'clock and take a look. And I did. And I took a look, and the baby had no heartbeat. But I really couldn't see anything specific at the time. That was 30 years ago, where we had black and white ultrasound that had so much definition. And so when I delivered the baby, the appearance was extraordinary. I can email you the picture.
Mhm.
Um, the baby literally was totally wrapped in its umbilical cord. It had a true knot of the cord. And what puzzled me as a scientist was, how could this baby be in this condition and not be detectable because of the usual ways we do prenatal care? So I began to pursue it by looking at literature. And I went back to the 1600s literature and worked my way forward to see what people had written about it. And the person that was the most involved in writing about it was an OB out of England named Dr. Smiley, who
Mm.
was from Lanark, Scotland. He was one of the original editors of the Encyclopedia Britannica. So if you look at the first edition Encyclopedia Britannica, he has several pages of lithographs of babies dissected for cord accidents.
Oh
And
my
he
God.
also has an interesting case report of a baby that over a period of 3 days died of a cord accident. So, it makes you wonder. I went back to, there's a museum in London called the British Natural History Museum, where they have hieroglyphs and Egyptian artifacts, etc. And I went back and looked at that, looking for any hint as to how much of this is known. And what the Egyptians used to do is they used to save the placentas in a jar. And then when that person died, in order to go to the afterworld, you had to be buried with your placenta. So
Whoa.
if you look at the hieroglyphs, you have 5 people marching in a line, and the last person has a staff. And if you look at it, on top of the staff is a placenta and umbilical cord. So, ancient societies were familiar with it. And if you go to Hawaii, there's a place where the royalty used to have babies called the birthing stones. And what they would do is they would take the placenta and bury it in the corner of their hut for future spiritual purposes. So there's 2 examples from 2 different places in the world of how people recognize there was a special nature of placenta, etc. And there's also a hieroglyphic of Cleopatra having a baby, but I couldn't find any examples of hieroglyphics, depicting stillbirth or cord abnormalities.
Mhm.
I'm still looking.
That's
I'm
fascinating.
hoping one day to go to the Cairo Egyptian museum and see if I could see something.
I went to it. After my son died, we went to Egypt and we saw all of it. We got the tours and we saw the mummies, we saw everything. I wish I had known this though, so I could have specifically asked if there's any portrayal of that. I mean, that is really fascinating because they portray everything. They're all just
Yeah.
stories. Yeah.
Well, I talked to a couple of experts who told me they were not aware of any specific hieroglyphics or records of babies being born in Egypt. So, you know, that's just the nature of the beast. And
It's not even referenced in the Bible even. There's in biblical times don't even reference it for some reason. It's really interesting that not a lot of history documents it.
yeah, well, people from way back when didn't consider that structure important.
Okay.
As it turns out, it's very important because it's an organ. It's an organ. It's not just a vessel. So it's an organ of embryonic development. The cord develops from the embryo to the placenta, not the other way around.
Mm.
So I've lobbied with the pathologist to depict it as a different organ system in pathology books, whereas it's still treated as a part of placenta. So you don't see any type of pathology textbook on the umbilical cord per se, although there is a discussion of it by a pathologist named Noye, Naeye. He was out of Pennsylvania. That's an interesting story. So the day that they give it its own separate categorization, I think you'll see more research into it because there's very little research into the umbilical cord.
Well, that's what's wild is we're talking about 4,000 years ago that they weren't considering it an organ, and we're now still not really considering it an organ. And you and I have spoken about this before, and it doesn't really get the attention that it really needs in prenatal care.
No, it has to get attention because it's a vital part of the whole picture. What I'm going to do is I'm going to send you this picture.
Okay.
Okay, I think I got it. Let's see if it comes your way.
Yes. Oh my goodness.
Yeah, so that's the baby delivered. I used to keep a Polaroid camera with me to take pictures of these type of events.
Oh my
And if you look
goodness.
at the baby, you'll notice that it's got 3 cords around the neck.
Mm-hmm.
It's got a body loop, and it also has a true knot. The cord is 100 centimeters long,
Mm-hmm.
and it also is what we call a 2-vessel cord. It had 1 vein and 1 artery. So this baby had multiple cord issues, and it passed at about 37 weeks. So that's what intrigued me as a scientist, is how could a baby look like this and not present some clinical signs that there was a problem? Well, as it turns out, 20 years after doing all this research, there is clinical information that can tell you a baby's having difficulty. And there is evidence that you can see these type of problems on ultrasound. And so people continue to suggest that you can't see these things with ultrasound. The next picture I'm going to send you is certainly an example of that. And so when you see these things, you need to pull that baby out of the routine prenatal care method and start looking at them on a weekly basis.
So you
So
said
what
the cord was 100 centimeters. Is that standard or is that short? Is that long?
No,
What is that?
average cord length is 55 centimeters.
So this was
So it
double
was
the length.
double the length. And you
And
know, to
that's
this
why
day,
it was able to wrap so much.
yeah,
Oh my God.
you can wrap as many times as it is long. And I was reading a paper yesterday where they delivered a baby, I think it was Syria, where the cord was 150 centimeters long.
Oh my God.
The longest reported is 300 centimeters. So
So you're telling me this is the ultrasound where you can actually see it wrapped around the neck 3 times.
yeah, that's another case. That's not my case.
But how come we're not doing this now? I don't understand how
Because it's being diminished. They don't want it. They don't want to do this. And I've been in several court cases where this came out. The OB community does not want this documented on an ultrasound because it obligates them to manage it, and they don't know how to do it.
Jesus.
Even though there are people that have published papers on how to do it. So that picture is from one of those papers.
Yeah.
So be able to visualize the umbilical cord is absolute, especially with color Doppler, and to look at its aberrations is absolute, and it's been published over and over again over 20 years. I have a room full of these papers. So that's what I do every week is I scrounge the literature like mining for gold.
Oh my
And I look
goodness.
for these papers to illustrate that this idea that you can't see this or do anything about it is a falsehood.
Well, I remember with Brody, my first pregnancy, I was just seeing an OB. I went in for a routine appointment, and they were like, "You're measuring small. Let's jump on an ultrasound." And we jumped on and he was slow that day. And I jumped on an ultrasound, and she was on me for like 5 seconds. She was like, "Heartbeat looks great," and I hopped off the table. He was dead 3 days later. So there must have been something going on that she just did not look for. Now, in my second pregnancy, I saw a maternal fetal medicine specialist, and I noticed that their technology is wildly more advanced, and they paid way more attention to the blood flow in and out of the cord. Is there a reason why maternal fetal medicine specialists have more high-tech machines while OBs just don't?
Well, the machines are expensive.
Oh,
And
well,
so
there you go.
to have the top end ultrasound machine, you're looking at $100,000. And in an OB practice, you just can't generate the cash flow to be able to afford that type of machine. But in maternal fetal medicine world, they can do that
Mhm.
because they get paid a lot of money to do that.
Wow.
So
Wow.
I'm going to send you a picture to illustrate uh, the history of this for you.
Do you have a platform somewhere online where you post your findings?
I used to.
Okay.
I used to do it, but I'm not very good at managing a website, so I closed it down.
Okay.
But what I did years ago was created a not-for-profit called Pregnancy Institute. It's still licensed, and that's basically how I represent myself.
Okay.
So what I'm sending you is from a textbook,
Okay.
and just notice the picture
Uh-huh.
and notice how what nomenclature they use. They're called coilings of the cord. And when you talk about coilings, if you go back in the literature, that word represents wraps.
Oh,
But there was
wow.
a paper published where the guy used hypercoiling to describe what was classically torsion, which goes back to the 1600s to an anatomist called William Hunter. And for some reason, that name stuck in the literature and it misrepresents what that is. Hypercoiling is the wrong terminology
Yeah.
because coiling implies a wrap around the neck, not a twist in the cord. Torsion represents twists, which implies the mechanical force of torque. You know, in engineering, they have to know torque to make cables and drilling pipe and these kind of things. So they talk about the torque resistance of cable. And if you over torque something, it buckles. And the engineering word is called a hackle. And so when these babies maneuver and apply twist to the cord like a self-winding watch, you're applying force, and the cord is only able to absorb so much force, in which case it fails, just like a drilling pipe, because it collapses on itself. So it can be explained and it can be visualized. And I'll send you what a picture of that looks like if I didn't do that already.
Okay. Now,
So go ahead.
in a pathology report after, if the baby dies of a coil or a wrap, and they didn't note that during birth, will it indicate on a pathology report, or will it only show like a cord compression?
Well, it depends on what the placental pathology is. In your case, I think it showed fetal vascular malformation,
Yeah.
which is indicative of interfered blood flow in the cord.
Yeah. Well, I'm still not sure if it was an actual compression or a clot. They won't, we
No, it
can't
was a
tell.
compression.
Okay.
The clot would come afterwards. But what I'm showing you again, I've now shown
Interesting.
you color ultrasound of loops around the neck. Now I'm
Okay.
showing you a color ultrasound of torsion of the umbilical cord.
Oh my, okay. So this is an actual coil, like a telephone cord, right?
Yeah,
Okay. So when we terminology use this nowadays, a hypercoil is this.
that's what
And
you're
I'm going to
looking at
hold
on
this
the
up.
ultrasound. Right.
When they say nuchal cord, that's wrap around the neck, correct?
Yes, that's
Okay.
correct.
Okay.
So,
Now,
my
what?
example to you is to show you, you can see these things.
Yes, yes. I remember maternal fetal medicine ultrasound showed a marginal cord insertion and then the blood flow in and out, but my OB hadn't really discovered that yet. So I just, obviously will always wish I saw a maternal fetal medicine specialist with my first child, but we don't always get to do that.
Well, the problem right now is there's a society called the American Institute of Ultrasonic Medicine, and the main obstetrical society, ACOG, relies on them to create standards, which is the word they use, as to what should be reviewed in an ultrasound. Now, they've suggested to review the cord insertion into the placenta on the ultrasound, but it's not an obligatory thing to do. So a lot of people just don't do it.
Okay.
But what's out there is an ongoing debate whether attachments like a marginal insertion create a problem. And I think what's missing in the studies is it's not just the marginal insertion, it's where it is. You have to do it in terms of 3 dimensions. So you got to know where it is and where it is relative to the whole uterus.
Does that cause premature rupture of membranes, the marginal cord insertion?
No telling. I think if there's consistent compression of the insertion, that it can trigger a pattern of premature contractions. But usually premature labor is attributed to inflammatory circumstances like a subchorionic infection. That all comes from a Dr. Roberto Romero out of Michigan. And I think that's probably correct. You get an invasion of bacteria, in between the membranes, and that gets chemistry going, and that chemistry triggers the contractions.
Yeah, yeah.
My point is all these things are detectable. They're not invisible. And so that's where the obstetrical community needs to review its policies, because these things aren't detectable, but you got to use different tools to do it.
Right.
You can't just go into a room, measure someone's belly with a tape measure, tell them they're fine, ask them if the baby's moving, and have the mom say yeah, and not explore the movement pattern, and then kick them out and say, oh, you're fine.
That's literally what happened to me. Literally.
Yeah,
Like,
I
it's like you were
described it
there.
pretty good, huh?
Oh my God. No, it literally is. And I kick myself so much. I go over that day so much because now that I know what I know, how was that okay? Like that just,
Well, that's my whole thesis, is that our prenatal care methodology is terribly flawed. We're not looking at enough details to evaluate pregnancies. The old issues of hypertension and gestational diabetes, I mean, those things are 200 years old, and we haven't changed the way we evaluate it. So they have to rethink prenatal care in light of modern tools, which is the ultrasound and the fetal monitor. But there's always a harangue over these things. And the harangue is, well, if you document these things and something goes wrong, you're going to get into trouble, because they're going to say, well, look, you knew about it. Why didn't you do X about it? And that's their fear. They're afraid of repercussions from having the information, because no one's developed what do you do with the information.
right.
There are no protocols that handle these type of things, and we still have gestational hypertension. No one
Yep.
solved it.
Well,
So
the hypertension, I was having my increased blood pressure, and now come to find out it was most likely from small placenta, and no one investigated it. It was, oh, keep on your baby aspirin, and we're going to induce if this keeps getting higher. And it was like, well, how
that's
high
all
is
you
it
can
going to
do.
go? Yeah.
Well, the only thing they have is baby aspirin at this time. There really is no other solution.
Yeah.
And that's a whole nother discussion. But the
Yeah.
last picture I sent you
Yes.
is an example that even at 12 weeks, you can measure the cord length and look at its characteristics.
Oh my gosh. Okay, I'm going to show another. If you don't want to look, hide your eyes.
Yeah.
I
So,
did not know you could see it that early. Wow.
not only see it that early, but see it that well.
So is this the length that will always be?
The cord length was originally described by Leonardo da Vinci as being as long as the baby, what we call head rump length.
Mm.
So it's proportional. You know, in art and in Greek art and math, nature is proportional. It's called the golden section. And so everything is proportional to everything else. So think of the Da Vinci circle with the man in the middle, where his arms are outstretched.
Yep.
That's a study in proportionality. And so all these things are proportional. It's some fundamental of nature that it is. So you could look at a picture like this, and if you use your pen, you can measure that cord length and match it up to the fetus, and you'll see that it's basically the same.
So as the baby grows, the cord will grow, but you're
Yes.
saying as a certain time, the cord may grow double in size while the baby doesn't catch up and vice versa?
Yes.
Okay. Wow. When does that
Yeah.
usually happen?
Well, the cord is always growing starting at around 26 to 28 days. That's when it starts to develop.
Wow.
And so the vessels are part of the embryonic cardiovascular system, and they grow through what they call the stalk and integrate into the placenta, not the other way around. So there's very little research on this. There's very little research on umbilical cord development. So there's a misconception in literature that the hypercoiling is how the cord develops. And that's absolutely wrong. Those are not what we call helixes. Those are actual 360-degree twists. So another misconception that is used, they use the word spiral, but spiral is an artistic term that means an ever-changing diameter, like a spiral galaxy. The cord is not spiraled, it's helical, which means it's a consistent diameter of turns. And even going back to William Hunter, he basically said that you have an average of 8 to 6 turns in a normal size cord of 55 centimeters. You can actually count this and measure this. And then if you put twists in there, and I figured this out with my own research, I untwisted over 1,000 cords at delivery and found out that the average number of twists is 3. So when you add 3 to 8, you get 11. And so even Hunter talked about having 11 turns in the cords. Well, that's normal development right there. You can actually count it, measure it, and know if the baby is developing torque.
Oh my
But you got to
gosh.
look at it to figure it out.
So how did you do that during delivery?
After delivery, as
Oh,
the baby,
after.
yeah. In other
After.
words, you cut the cord and then you untwist it till it looks like it's in its normal state.
Okay.
So
So we're talking all about this lack of attention to this. What can we do as the mom at this point? You know, I know we always say advocate for yourself, but what would that even look like at this point? Like demanding they take a look at a certain, like you have to know your stuff now in order
yeah,
to ask doctors specifically what to do.
well, you have to ask them to look at these things.
Yeah.
Say, I want you to take a picture of the cord, and I want you to take a picture of where the cord is attached to the placenta, and I want you to give me a copy. You have to demand it.
Oh my word. Yeah, we got to get bossy. We got to get confident.
Yeah.
We got to stand up and do that.
That's the word. You ever seen this girl on the commercial? Her name's Judy.
I don't know. Wait, what commercial?
What is it? It's a cleaner.
Okay.
My boss or something cleaner.
Okay.
The personality, the actress is deliberately being very bossy, and it's really funny. So
That's what we have to do, and people are
yeah, but
terrified to do that.
that's what you have to do to get these people to do what they're supposed to do.
Do you have people sending you pictures and being
Oh,
like,
yeah.
what does this mean? Okay.
All the time. Yeah, and the last 2 weeks, I've had 3 moms call me about torsion deaths, and half the time the OBs don't even know what it is when they see it.
Oh,
So I'm going to
Jesus.
send you a picture,
Okay.
and I'll explain it to you when you get it.
Okay. Oh my. Oh my. Was this baby living?
Yes,
Oh my
because
God.
it didn't exceed the torque strain uh, strain of the cord, so it didn't collapse. That's why the baby's alive.
Jesus.
So what you're looking at are helixes and twists in the same cord. So I'm
And
gonna send you another.
this can be seen on ultrasound, correct?
Yes, it
Can
all
you
can be seen on ultrasound.
can you tell how many times on ultrasound?
Yeah, you can count it, but
Okay.
that's not the best way to do it.
Okay.
I'm gonna send you another picture, and then I'm gonna follow it up with another picture.
Do we know how the baby even manages this?
Well, the baby can manage it. You mean manage to get into it, or
Yeah,
be able
yeah,
to?
yeah. Manage
Yeah,
to get into it.
the the baby is reflexive, just like you blink in your eyes with dust in your eye. And
Okay.
so when it gets stimulated, which is mainly an interruption of its blood flow for some reason, it maneuvers. And so, like a self-winding watch, the baby will literally spin in the womb. And if it spins in a certain XYZ axis, it applies twists to the cord instead of getting wrapped.
Yeah.
If it rolls over, well, then it can wrap itself. So these twists are because the baby is maneuvering relative to the placenta, so that it doesn't wrap. It just applies a 360-degree twist to the cord.
Do you know if, obviously we feel movement. Do you know if that particular movement is indicative of, like, could we be able to tell that this movement is different?
No, the only thing
Okay.
about movement is you'd be able to tell the strength of the movement.
Okay.
All right. So the next two pictures I'm sending you shows you a baby. And if you look at the picture of the baby, he's pale, he's floppy. It's actually a she. The
Yeah.
baby has torsion. It has a cord around the neck. And then
Oh
if
my
you look at
God.
the right side of the baby, it goes down under his knee.
Yeah.
All right. So this mom came to the office for a visit and told me the baby wasn't moving that morning. So I brought her to labor and delivery for that reason. And you could see the baby's heartbeat was abnormal and delivered the baby. So the next picture is the baby at 20,
What?
Jessica.
Oh, that's her? Oh
Yeah,
my
that's
gosh.
Jessica. Yeah,
Wow. Wow.
that's the baby. So, the example of the case is that there is a way to be aware that the babies might be getting into difficulty. There's a lot of controversy about counting fetal kicks. To me, there's a better way to do it, and that is to be aware of your baby's behavior. I use the word behavior. So every night when you go to bed, when you lay down, your baby moves.
Mhm.
It's a reflex, and there are reasons for it. And so if you feel the baby is moving at night when you go to bed about the same, good chances are your baby's fine. So, but if you go to lay down and the baby doesn't move or moves very poorly, well, then there's a problem.
Yeah.
So I use the word fetal behavior and to be aware of bedtime fetal behavior more so than kick counting.
Interesting.
Because if you tell the mama to count kicks, she may be counting movements, not kicks.
Right. Right.
The guy who originated that observation was out of Israel, and he meant kicks, punches, not just movement. And so people have misinterpreted that paper for years, thinking that any kind of movement is countable, but it's not. That's not the way it works.
So
I'm
if this woman had waited any longer, this baby would not have made it, obviously. So do
No.
you have a timeline of
Well,
when movement slows or stops?
well, if you go back to the original Smiley paper, case reports, he wrote a book with case reports. That baby died over a 3-day period and had 2 cords around the neck. So there is a controversy that I try to address where they said the babies die immediately. No, they don't. They die over time. They could be trying to compensate, which they can do over a period of days, like a marathon runner, and then they finally collapse.
Mhm, mhm.
So these babies don't die instantly. There is time to find them and to evaluate them and to possibly deliver them if you have to.
Okay.
So the next picture I sent you is a baby that delivered in the emergency room. The mother had no prenatal care, and it's a really good example of what a torsion looks like.
Yes, yes. That is
Yeah.
that's a very long cord.
So if you count all the turns, you get like 24, 25 turns. And then if you untwist that cord, you get 15 twists,
Okay.
and the rest are the inherent helixes. So the value of that picture is to be able to explain what torsion is and how it works. So it's not an uncommon problem. It just doesn't always cause death of the baby.
Right,
But
right.
it's there, you know. So if you were to do a study and you want to do a study on torsion and how it impacts pregnancy, there's no database in the world that has that information. And
So you said something interesting on our phone call about needing to know the length of the cord,
right,
and how much they have left. So if the cord is measuring small and they've been wrapped in it, they have no space left.
no slack.
No slack.
Yeah.
Yes, yes, yes. So I found that very interesting.
Yeah, and
Wha-
that's never taken into account. So
Right.
if you look in a database, nobody has a picture of the cord and placenta in their database, and they don't untwist the cords and count the twists or put in the length. So there's no database in the world that can look at this question because they don't have the details to answer the question. So a lot of the opinion is based on guesswork. It's not based on details. But I detailed that over 1,000 deliveries to understand it, and now I understand what it is. And so they continue with the verbiage of hypercoiling, which is incorrect. It gives you the wrong idea about it. It's torque, it's torsion, very common in horses, and it has to do with fetal reflexes and how the baby reacts in the womb.
And that's why some babies can be delivered alive with the cord around their neck and some aren't, is because of the length and the
yeah,
placement. You said the placement in the placenta, right?
yeah. Well, how much do you have left? How much
Right.
length do you have left? Yeah.
Right.
Let me see if I can send you a poster that shows that.
Okay.
Yeah, none of that is taken into account, unfortunately, and it has a lot to do with how you do this.
So if you're telling your doctor to take a look and they can see that the cord is attached to the placenta at the top and it's also wrapped around the baby twice, you could see how much length slack you have left. And then if it means an early delivery to get them out before they get too big, then that's what you would have, the precaution you would have to take.
Well, what you want to do is evaluate the baby based on his heart rate
Right.
and his behavior before you decide to deliver a baby early. I mean,
Right.
that's what you got to do. Yeah, I'm looking for a particular photo for you. Haven't found it yet. I'll send you this one. This is another picture. This was published quite a while ago, showing 4 cords around the neck with ultrasound.
I hear 4 is very rare. Is that true?
Yeah, but if you saw this baby on ultrasound, you would definitely start watching this baby on a very frequent basis.
Okay.
And
Okay.
like I said, you can only have so many wraps before you run out of length.
Yeah, you're right. Wow. Now, you also have theories about knots being formed from it being wrapped. Is that right?
Right. Yeah. It's very easy to prove. The baby starts off with what they call a hitch instead of a wrap. As the baby maneuvers, the cord buckles on itself, and that buckle goes over the head and forms a hitch, just like hitching a horse to a post.
Okay.
And those loops come down the body over time because of the way the baby behaves. And eventually, when they're delivered, they come off the feet as a knot.
Interesting. What is that, a true knot? Is that what that is?
Yeah.
Okay. And what about all this Wharton's jelly talk about how some women have more or less, and that's why some babies live and don't? Like, what is all that?
Well, that's just variable. There
Okay.
isn't really a lot of research on Wharton's jelly. but the little bit that I could find, it's equivalent to what starts to build bone, what they call the bone matrix.
Okay.
And nobody knows what controls it, what genes develop it, and whether you can affect its thickness or thinness. That's unknown.
Does early delivery sometimes save these babies? Do we know?
Well, yeah, that was the Jessica baby.
Okay.
Yeah, she was early.
Even if though, let's say baby's heart rate's fine, we could see that it's wrapped several times though. Would an early 36, 37 just for precaution be acceptable?
No, you wouldn't do it as a precaution. What you would do is you'd put the baby on labor and delivery and put the mom on constant monitoring. And then if you saw alterations of the heart rate, what we call decelerations, then you could make the decision to deliver the baby. But I wouldn't deliver the baby just because of the wraps.
Would
The
you
wraps are
opt for C-section in this event?
not necessarily.
Okay.
What you could
Okay.
do is you could get them going as far as a vaginal delivery goes. And as long as they can deliver vaginally if they don't run into some type of cord obstruction.
Okay.
So yeah, you can do that.
I also want to ask you, I mean, it's all the same subject, but I hear a lot about clots in the umbilical cord. And that you can't tell, and they like wash away. And so a lot of people don't actually know if there was a clot or not. I have a clotting disorder that I found out about after Brody died. And a lot of us now know that we have this. How common are these clots in the cord? And is it the same situation as monitoring behaviors that would help? Or is that instant? What is that?
No, there's no way to monitor for a clot.
Okay.
All you would be able to do is notice if the baby's behavior changed.
Okay.
But they're not that common.
Okay.
So it's not on the top of my list of cord issues. So I
Interesting.
finally found the diagram to explain to you about placental position and cord length.
Okay.
So if you look at the top two images,
Okay.
the placentas are anterior. So this lady had a loss due to a double nuchal cord, but she had other babies with cords around the neck. But when you went back and looked at the ultrasounds, the only baby that had the fundal placenta was the third baby. And so what is depicted in the diagram is that the cord is under tension because of the double nuchal cord.
Yep.
And that's what caused it to die.
Oh God.
The other
Okay.
babies don't have that relationship. Their placentas are either anterior or the one that's posterior. So they have plenty of slack to deliver with.
Okay.
So in the obstetrical planning, we don't plan delivery. We should be putting in the notes, this baby has a fundal placenta with a marginal insertion, make note of this if the baby isn't descending or the labor isn't going smoothly. And so you would know that already. The fact that we don't have that type of information in a obstetrical note means you're basically laboring blind. So, you're going to have a sudden event and you're not going to know what it is.
Yeah.
You're going to sit there trying to figure out what it is, but you're not going to be able to because you can't figure it out just because the baby's heartbeat slowed down. If you had this information in your head with a particular patient, you would be able to figure it out and you would be able to act on it because of what you already know.
Right.
So it's a hole in our prenatal information assessment is my point. We have to know these details and they need to be in the OB record and they need to be in the delivery record. Or if you go back to do studies, you're never going to figure it out because you don't have the information to figure it out with.
Right. Why is there such hesitation to further advance or learn or educate on this subject?
It's just a difficult subject.
Yeah.
It's obstetrics is not a well-known innovative specialty.
That's so wild. Why?
Because they've had bad experiences in the past with people that have tried to do things and they turned out badly. So they're very sensitive to it. The worst was the cerebral palsy lawsuits that came out of the 80s because of fetal monitoring. And people used the fetal monitoring to say the babies were getting brain damaged and nothing was done about it. So that group of academicians, they're in their 80s now, and they were very sensitized to that era because of the massive number of lawsuits that were taking place, blaming OB doctors for cerebral palsy. But as they found out over time, the injuries were before labor.
Wait, so
So
were they saying that the ultrasound technology was hurting the babies?
no,
Okay,
well,
what
that
were
the
they saying
fetal
the cause was?
monitoring, the
Okay.
fetal heart rate monitoring was not being properly interpreted.
Oh, got it. Okay, okay. Okay, but you're saying cerebral palsy was coming from another source.
Yeah.
Interesting. So you're saying if they come out and they're like, okay, we need to start monitoring these cords better. We're now diagnosing what we're seeing. We're taking precautions and we're saving these babies, that the ones that were not saved could come out and sue?
No, they won't be able to do that
Okay.
because the quote standard of care is that you don't have to look for it.
Interesting. You're right. The standard of care. Yeah.
So that's where the legal argument's going to go to standard of care.
Yeah.
And I had a very interesting experience. There was a maternal fetal doctor out in Colorado that diagnosed and recorded 5 cords around the neck of a baby and did not follow up on that, and the baby died.
Jesus.
And he defended himself with other maternal fetal medicine testimony that basically said he did not have to follow it up, that doesn't cause a problem. So he won his defensive case. So that's what's going to be out there. I run into it all the time. I have a paper sitting next to my chair that I pulled yesterday of a group out of Texas that basically says the same thing, that if you see entanglements or not, you don't have to do anything about it because it doesn't cause a problem.
And they're not even telling the mother.
No, a lot of these institutions do not tell the mother, and the technicians are told not to tell the mother.
Oh my God.
So yeah, that's all unnecessary, but that is the current, trend of what to do about this. There are a lot of people that publish papers to suggest that you don't have to address this problem. What they're missing is you're not looking for the baby that's going to survive. You're looking for the 1 out of 100 entangled babies that's not going to survive. That's the one you're looking for. So don't sit there and say, oh, well, it doesn't cause a problem, don't worry about it. No, keep looking to find the baby that's not managing it properly and is starting to deteriorate. That's totally doable, totally possible. That's based on those 2 pictures I sent you with the multiple wraps. And, that's just not the way to approach it.
Yeah. So I feel like a lot of times the doctors are looking for everything to be fine instead of looking for something that's going wrong.
Right.
Wow. How do we
Mostly, out of
change that?
1,000 deliveries, most is going to go fine. The trick to being a good OB is finding the 1 out of 1,000 that's not going fine.
Jesus.
That really tests your abilities to manage OB patients well. You got to go find the baby in trouble. That's your job. And you're going to go through a lot of moms that aren't having any problems. That doesn't mean somebody else isn't having a problem. But, sooner or later, you're going to get burned,
Yeah.
maybe in 3 years, and you're going to hit that baby that was having a problem that you weren't paying attention to.
Yeah.
You know,
And
the
I think
mother
it
may have
has to
told you,
happen though. Like the only way they change is to experience a death on their watch. But the ones that infuriate me are the ones that don't change, even if they had a baby die on their watch.
well, you have institutions that promote their policies, and an individual is not going to likely buck up against an organization that's saying you have to do this.
Mhm.
So that's just not something that you see on a regular basis. Those type of individuals are very far and few between. So
Do you have any that come to you to learn or research or rally to try to get some change going on?
no,
No?
no.
I wonder why.
because it's not a popular topic. Stillbirth is not a popular topic. So, you know, I've had encounters with some of these people where they feel like it's a career killer if you promote stillbirth research and do things along those lines.
What?
So, yeah. So what you see is you see people entering this topic and they'll write a paper willy-nilly. They don't have the information. And so they come to a conclusion that's completely aberrant because they never comprehended the issue. It took me 20 years to comprehend this issue
Right.
and begin to understand what was going on with these babies. It's not something you can just hand over to a resident and say, go write a paper on true knots and think you're going to get it right, like this group did, you know, out of Israel, where they couldn't even describe how the knot was formed. So what I do is I write an email to these authors and say, you know, I enjoyed your paper, very interesting, but this is how a true knot is formed, not the way you described it. And then they make conclusions as if to say they're the authority on the idea after writing one paper. They're not. They don't get it right at all, and they don't have the fundamental information to get it right. So,
Are you seeing other countries paying more attention now and making some change happen? Are we the only ones that aren't?
no, there are
Okay.
other countries looking at this, and
Yeah.
they have the same clash of ideas, the people that believe it's an issue and the people that don't think it's an issue. So that it's going on pretty universally. It starts with education, and most of these places don't have conferences that address the topic. So, I mean, you can go across the country to OB meetings and you'll never see a lecture on umbilical cord pathology.
Unbelievable. I don't, it's the lifeline. I don't understand it.
So it's not a popular topic. They don't want to talk about it, and they don't want to be obligated to evaluate it because they're afraid of getting it wrong because nobody knows how to get it right.
Jesus. Okay, so if I go in and I say, this is what I want you to look at, what is the checklist? And then basically we're saying that they may not even know what that means or what to do if they find certain things. So then we can send it to somebody like yourself to say, can you take a look at this? So what is the checklist that we want them to look for?
Well, what they have to do is they have to get an image of the cord relative to what it looks like. And they have to get an image of where it attaches to the placenta to see if it's marginal or what they call villaminous. Those are fundamentals that you should know by 20 weeks.
Okay.
And everybody should be looking at that. But it's not obligatory, so nobody does.
Yeah. So anatomy scan, we found the marginal cord insertion. But honestly, Dr. Collins, it was like, oh, there's not enough research to say that this is a big deal. Usually we see it in twins. So it may be growth restriction. That's all you're
Well,
going to see. And I'm like,
actually, there is enough research to say
ugh.
it's an issue. So that statement is incorrect. As a matter of fact, it's a very common issue with IVF patients that are infertility patients. That method causes a lot of marginal insertions. And nothing's worse than going through an IVF procedure for $10,000 and having your baby die at 7 weeks because of compression of the marginal insertion. So
Oh my God, that can happen at 7 weeks?
happens no, it's at 37 weeks.
Oh, 37 weeks.
Yeah.
Does IUI cause that as well, or just IVF?
IVF is all on, that's published. These things are published.
This is
And so, yes,
wild.
there is published information about marginal insertions causing poor outcomes. That exists.
My God. I got looked in my face like this is not a big deal. And then my baby came at 32 weeks and they won't talk to me.
Well, why won't they talk to you?
They don't do follow-ups, quote unquote. They won't talk to me about what happened. They won't talk to me about what do I do next pregnancy. Like they won't talk to me. So
Well,
I had to
there's no
switch
reason.
offices.
Yeah, well, there's no reason not to talk to the patient. I
Thank
mean,
you.
I talk to people every week that I don't even know and have never met that are calling me from across the country about what you just said. They don't know what happened to the babies. Nobody's telling them anything. And I think that's tragic that this is going on. Those people should be brought back to the office and should have an explanation of what possibly happened. I don't understand the behavior, frankly.
It's horrible. They told me to get in line because I'm not pregnant anymore. I have to start over and they will not do a follow-up. And I have to wait for a preconception appointment. And I think that I got so upset like, that something happened while I was in your care. Why won't you talk to me about it? So I
Well,
fired them and I have to go somewhere else now because I
yeah,
thought that
that's
was
all right.
ridiculous.
Well, there are guidelines that say they should be talking to you.
It's
So
unbelievable.
they're not doing their job is what it boils down to.
And that's happening a lot because I think
Oh,
people
yeah.
don't want to be held accountable for something going wrong when they
Yeah,
missed it.
that's what it's about. That's what it's about. Now, I sent you another picture,
Okay.
and basically there are 8 different types of cord morphologies.
Whoa.
So I want you to look at that picture
Uh-huh.
because not every cord is the same. They developed in different ways. And they even look differently in other animal groups, like primates and horses and cows and
So
goats.
you have 2 vessels, 3 vessels, 4 vessels, and 5 vessels.
Yes, all those are possible.
Wow. Now, what are the risk factors for each one of these? Like if you have 5 vessels?
Oh, nobody knows.
Jeez,
Nobody knows.
I hate it
What I'm
here.
showing you is unusual. Nobody knows this breakdown. And so what you'll hear is, oh, well, babies are born all the time with cords around the neck and they do fine. Yeah, well, the reason that that's an error is because they're not all the same. So you have cords that are thick, you have cords that are thin, you have cords that have different venous artery relationships. So you can't say they're the same. They're not the same.
Yeah.
The ones that are dying clearly have something wrong with it that caused the death. Not that it's benign. It's not benign when it's in the right combination of factors. And in order to figure out this, you have to know all the parts. You have to know what the cord looks like, what the insertion is, where the placenta is. And those are all essential elements, details that does not exist in any database. So you can't get to the right conclusion, which is out there, that says, oh, baby's cords around the neck are not a problem. You don't have to do anything about it. Yeah, you do. You got to pay attention to it. And you better be looking at that baby so that if you see a cord around the neck, 2 weeks later, it doesn't have 2 cords around the neck. So these things can come and go and multiply and or have a cord around the waist or a cord around the ankle. You got to go looking for these things if you're going to get it right. Chances are, if you don't do that, then you're going to miss the 100,000 babies that's in trouble. You're going to miss it. So that's what's out there. But every time I see a paper like that, I respond to it and write an email and send this information to the author to say, did you take this into account? Did you take this into account? If you didn't, then you don't have the right answer. And I had a paper not too long ago that did something similar. And I wrote the lead author, and the lead author wrote me back and she said, very interesting. I agree with you. We don't have that information. I'm going to try to go back in my database and try to get it. Well, you're not going to get it because it's not there to begin with. You got to start from scratch and build it into your database. But I doubt that anybody to this day has anything like that.
Oh my gosh. Well, in medical school, is any of this covered in detail at all?
No, not at all. I
Uh,
had to go digging through many textbooks and many papers. I have over 2,000 papers on this topic to get to the answers I'm giving you.
is there anyone else out there doing your work?
Not on a regular basis like I am. Every now and then something will pop up, but these are not someone who's dedicated to the topic.
Right.
They just decided they were going to write a paper on this issue because of the winds, of trends. So right now, this is not a popular topic.
Do you get any pushback or backlash or anything of the sort from current medical professionals when you try to speak on the topic?
Not directly, but indirectly.
Okay.
I've yet to have anybody willing to converse with me directly about it. So I don't know why they don't.
Yeah.
That's not the academic way. The academic way is to have the conversation.
Yeah. Do you think there's hope? Do you think that we'll ever see a turn in this? Or is
Yeah.
this always going to be in the hands of the mother?
No, it'll turn because the technology is getting better all the time. So, ultrasonography is becoming extremely detailed. And so as that comes about, and as the pathologists who get all this, the pathologists don't have a problem with what I'm telling you.
Right,
They get all this.
right.
They can look at the placentas and tell what's going on. And so it's just the OBs, but as the ultrasound becomes more refined and we get better at censoring the baby, probably at home, which I've done, then you'll start seeing these things and they'll have to deal with it. So I'm
Have
going to
you,
show you how far back I go with this stuff.
well, in your career then, on that note, have you seen an increase in deaths? Do you think the number's increasing, or are people just becoming more outspoken about it?
No, I don't think it's increasing.
Okay.
As a matter of fact, in other parts of the world, India and Eastern Europe, I think they're catching on to it. So I want to send you this to show you.
Yeah.
This is the first paper that I published with the American College of OB/GYN. So
ACOG, geez.
yeah, that was 1991, by the way.
They have actually started to like silence a lot of us, which is really interesting, like not
How
letting
was
us
that?
comment, taking down comments on their posts. I believe there's been 4,000 or so letters written from stillbirth mothers saying we need to change our prenatal care, all ignored. They're not willing to listen. And I find that very interesting. And I think it
Yeah,
just
it is
all goes
very
along
interesting.
to what you're saying. Yeah.
Well, I have an OB/GYN mother that lost a baby to this, and we helped her with her subsequent 2 pregnancies where the first baby was lost to a double nucleocord, and the second and third baby both had double nucleocords.
Oh my God.
And we were monitoring her at home, and we caught both babies getting into difficulty and got them delivered. Her name's Dr. Finkelstein. She's out of New Mexico. And when ACOG wrote its last stillbirth bulletin, I showed it to her and asked her to write a letter to the author, which she did. And, she berated the author as saying, you're not solving the problem. You need to change your attitude about it. So we've approached them in many different ways with patients, doctor patients, science, examples
Mm-hmm.
to say, you got to stop ignoring this because it's becoming too apparent through published literature that these things are doable and you're not addressing it.
They're not. They're ignoring it. I don't
But
understand it.
I think as the ultrasound imaging becomes better, they're not going to be able to ignore it anymore.
I hope it does get better, and I hope it's affordable by these doctors' offices. I mean, I have seen some really rough looking ultrasound images where I'm like, what is happening in there? You can't see anything. But then you go over to, reproductive specialists, which are like NASA cameras. And then you've got maternal fetal cameras, which are monitoring the blood flow. I mean, it's wild how different it all is. And
Well, there's a company out of Vancouver, Canada called Clarius, which has a $2,000 handheld ultrasound where you can send the images to your iPhone. And those images are very clear and very good.
whoa,
So I believe in the future, mothers are going to be scanning themselves with $1,000 handheld ultrasound units, and they'll be monitoring themselves at home once it becomes available to the public. That is possible today, but you need a permission from your OB to let you do it, and a lot of them don't want to do it.
no.
So I got moms calling me up about it, but I tell them I can't help them unless a doctor gives them a script to do it, and the doctors refuse.
Oh
So,
my gosh.
all that's going to shift for a variety of reasons,
Yeah.
but that's where it is today.
Well, I have a feeling after this airs, you're going to get a lot of mothers reaching out, if that's okay.
Yeah, I like talking to the moms.
Yeah.
The more moms I educate, the sooner this is going to get better.
Yeah.
You know,
What's the best way to reach you in that situation?
email.
Email. Okay. So I'll provide your email if that's
Yeah,
okay.
you can
Okay.
do that. Yeah.
Um,
I want to talk to them because I want to hear the stories
mhm.
because it helps me to verify what I've come up with after 20 years of research.
Yeah.
So what we know, we're the first ones to publish these babies tend to die at night between 2 and 4 in the morning.
Oh my
There are
God.
reasons for that. And I've yet to hear a story that contradicts that. And when I listen to the symptoms, it verifies the clinical signs that are out there. Babies that are getting into trouble have lots of hiccups several times a day.
Oh my God, mine did. Mine, I was told that was proper lung development. He had hiccups all
No,
day.
no, that's fiction. No, hiccups is a reflex,
Oh my
and it's a
God.
reflex that relates to the baby's blood flow being disrupted in the cord. And you get a pressure wave if you compress the cord, and it goes up to what it's called the ductus venosus, which is a vessel that connects the venous return to the heart and the baby. And that's wired to the baby, and it causes hiccups, which if you think about it, the baby's trying to hop off the compression.
Oh my God.
So it's a reflex of the baby to protect its blood flow. So hiccups that are repeating themselves on a daily basis is a clinical warning sign. And I've presented that for the last 20 years. I presented that at a European meeting and had a man stand up in the audience screaming at me, told me I was a liar.
Well, because I immediately, I feel guilt, I feel blame, I feel like I should have known that, and I feel like that's
Well, how
people's
would you
reactions when they get mad.
how would you know it if it's not written anywhere? So,
I was literally told it was a good sign, both pregnancies
yeah,
of
that's
proper
out
lung
there.
development. Okay.
Yeah, no, it has nothing to do with lung development.
And babies, I hear about, and my baby got quiet from here and there and then would start moving again. And I was told that was
Yeah,
normal because they sleep and sometimes they, you can't feel them. But is there a chance that they are compressing over a very long period of time and they'll
yeah,
decompress it and then compress it and go back and
yeah.
forth? Okay.
It's called intermittent core compression. Yes,
Jesus
indeed.
Christ. Jesus Christ. I mean, I don't know how many signs I could have had, and my OB literally did not catch them. And it's infuriating. And I'm sorry that I'm upset. It's just so
Well,
terrible.
all I can say to you is that it's not taught anywhere. So
So
your
you're
OB,
saying they just don't know.
they don't know. No,
Jesus.
you
That's
can't read
scary.
it anywhere and you can't hear it anywhere. It's not at any OB
Yeah.
meeting. There's no lecturer on umbilical cord pathology at an OB meeting.
It just
So
makes me sad. There's so many mothers whose lives are just completely shattered and so many babies that are dead. It's just not a pregnancy loss. It's what they kind of treat it like. It's a
well,
death.
the position of ACOG is the cords don't cause death. And
That's
they actually put that in writing. There's an ACOG
really,
bulletin where it says if your baby's born with a cord issue, look for another cause of death. So they don't accept cord malfunction as a cause of death, even though there's hundreds of papers in animal models, even rats, that show that if you have intermittent compression of the cord, the fetus collapses after about 45 minutes. So the evidence is out there in animal models, but then you get the person that says, well, that's not a human, you can't equate the two. And I'm like, people equate the two all the time
yeah, all
in
the
drug
time.
research and other things. So, it's just an
Wow.
excuse not to address the problem. So,
Oh, yeah,
my nature is to address the problem. I like to problem solve. So
you
I
do.
found
And I
it to be
appreciate it.
very challenging as an issue. And the more I dug into it, the more I began to understand why it still exists, because nobody is studying it properly, even back to William Hunter. So since the 1600s, all they did was make observations, but nobody really did an evaluation because the tools didn't exist. But
Yeah.
today, you have ultrasound and fetal monitoring, which are tools where you can look at these babies that are getting into trouble and you can get them out of trouble if you're paying attention. And that's all it takes, is paying attention to the baby that's telling you, I'm in trouble. And there are ways to know which babies those are.
I mean, you're doing work that is so appreciated. And I think you're helping so many because it just feels like nobody else wants to help. So, and I know it's not easy. So I'm so thankful that you are doing this and educating us because I don't know if in my lifetime I'll ever see anything change. But I do know I have the tools as much as I possibly can to try to get my babies here alive.
Yeah, well, if you're a lost mom, your chances of another loss is 5 times. That comes out of the National Institute of Health, and Dr. Reddy did that. There's some other studies, one's out of Michigan that says it's 10 times. I think that's a little high, but it depends on what caused the baby to die.
Right, right.
And then, that depends on what your chances are of another problem. But the thing
Right.
is that the bottom line is a mom that lost a baby needs a lot more attention an investigation on her subsequent pregnancy because she's so terrified. And so you got to give it to her. You got to give her the attention. You got to do multiple ultrasounds, multiple testings, so that she can go through her day-to-day life without being terrified something's going to happen again.
Thank you for saying that. There's a lot of doctors that will not give that to mothers who have lost. And I try to tell these moms, you got to get another doctor. A compassionate, good doctor will help you through the next pregnancy.
Yeah, I don't understand it. My nature is to do that, but I don't understand the resistance. Why they're not wanting to do it? So you might hear things like, well, the insurance isn't going to pay for it. Well, when you have your baby, go get a lawyer and sue the insurance company. That's what you do.
I like
Yeah.
it.
Yeah.
I like it.
Oh, well, we don't know how to do that with ultrasound. We'll go get somebody who does.
Yeah.
Because if you don't know how to look at the umbilical cord, how can you be maternal fetal medicine when you're supposed to look at blood flow in the cord to look for IUGR babies? Then you're not trained properly,
Right.
and you shouldn't be in maternal fetal medicine. I mean, this is the kind of stuff I hear all the time from these moms.
Yeah. It's pretty
We
wild.
don't do that. We don't know how to do that. That doesn't matter. And I'm like, man, oh man, oh man, you must not be reading your own literature.
It's
It's
like
all
they
out
don't,
there.
yeah, no, they don't stay up to date or anything. They don't, it's,
No.
and if they see something that's kind of wrong, quote unquote, or abnormal, I feel like they should then go look it up. Like, how do I treat this? You know, it just doesn't feel like that. There's so much, so
Well, to
much
tell you the
ego.
truth, in this arena, there's nothing to look up. It doesn't, it's not
Yeah,
out there.
yeah, yeah, you're
You
right.
know, the
You're
last
right.
paper that I published talked about why you need to do this with ultrasound. So I don't know that anybody took it seriously, but 10 years from now, there's going to be some resident looking up literature. He's going to come across the paper and say, oh, look what this guy was saying 10 years
Amazing.
ago.
That's amazing.
Yeah.
I mean, I
I've come
hope you don't
across
ever
it.
stop.
No. I'll continue to do this because it's such an incredible issue. It's a solvable problem.
Yeah.
And so I don't see any reason why it can't be intertwined into prenatal care. You can solve this problem. We're the first ones to report a true knot on ultrasound. We did it first.
Yeah.
And when I did it, I had professors up north saying that wasn't what was on the picture. One in particular got all over me in an editorial saying I didn't know what I was doing and I didn't see that and that didn't happen. Well, that baby's 32 years old now. And so I gave the editorial to his mom, Evan Huff, and gave the mom his number, at the university. And she called him up and cursed him out. Said, I was there. I saw him do it. My baby's alive today because he was watching this.
Mhm.
And one night we saw D cells and I delivered Evan. So,
What it's going to have to take all of us getting roll out.
but she chewed him up and down for his comments. He didn't know what he was talking about.
Good.
Mainly because he didn't know how to do it. And
Mhm.
so he was commenting on his own incapacity.
Ego. Yeah.
And the title of his article was, Don't Look for Loops Because You'll Hang Yourself.
Oh
Now,
my God.
how in the world did he get away with a title like that in a major obstetrical journal? I mean, the editors should have trashed his title before he even got started. But I later found out that the editor that was in charge of that issue was his colleague.
Oh my
So
God.
that's how he got away with it. But let me tell you
Everything
something.
is so political, even this. My
Oh,
goodness.
yeah, this is a very political topic.
I hate it here. Oh my God.
Yeah.
Okay.
I still go to meetings and try to initiate conversation about it, but it's not welcomed. So
I'm thankful you haven't backed down. I mean, this
Oh, no.
is life changing
I
for a
have
lot
no
of
reason
us.
to back down. These people don't impress me.
I
You know,
knew I
they're
liked
not
you.
doing their job as academicians, and they know it.
You
They
must
know
get
they're
so
not doing it.
frustrated. Yeah. It's frustrating, I'm sure,
Yeah.
to witness. Well, I know we are time. I don't want to take up your whole Saturday morning, but I
Oh,
would
that's
love
okay.
to do, if you're willing, I think we're going to have a ton of questions from this episode. I'd love to bring you back on and answer some of them. Would that be okay?
Sure.
Okay.
Sure. That's
Is there
okay.
anything we didn't touch on that you want to leave with here?
Well, I just want to tell the moms, insist on the ultrasounds, insist on them looking at the cord and its attachment to the placenta, and insist on getting a copy of the photos. Because if the technicians are being told not to document it, or it's not being put in their prenatal record, they have a record of it.
Okay.
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 So that's important for them to protect themselves in the future. If something goes wrong, they can say, well, they knew about it, but they didn't do anything about it. And it's going to take that type of pressure to wake these people up.
Absolutely.
They're not awake yet. Right now, they're in defense position where they're trying to neglect and deny this stuff because they don't want to deal with it.
Oh my gosh.
So that's
Well,
my message.
this has been so helpful. I appreciate your time so much.
Yeah, well,
And I want to keep
it's
this
wonderful
conversation
meeting you
going.
and getting to see who you are. And,
Thank you.
you know, it will get better. It is doable. If they can solve COVID and AIDS and polio, they can solve this.
You're right. Well, I appreciate it again. A conversation is open. I will put your contact information in the description so people can reach out, and I
Yeah.
will do a question and answer coming up in the near future here to try to get some answers for some mamas that were listening. But again, I hope you know how much I appreciate this. It's
Oh,
very rare to have anybody take the
actually, I
time.
appreciate you inviting me on your podcast because I don't have a lot of options to get these messages out. I had a website for a while, but it just wasn't worth it. So this
Oh,
is nice of you to,
I'm here to amplify your voice as much as I can. So,
well, this
um,
is nice of you to do, and I
yeah.
thank you.
No, thank you so much. Well, enjoy the rest of your Saturday, and we will
Okay.
be in touch soon. Okay.
Okay. Look
Thank
forward
you,
to it.
Dr. Collins, so
All
much.
right.
Bye.